Hi, I'm Christine, and the article I studied was Voice Abnormalities and Laryngeal Pathology in Preterm Children. So according to the WHO definition, a premature or preterm infant is any infant that was born prior to 37 weeks of pregnancy. There are 3 subcategories it puts this in, and those are extremely preterm, very preterm, and moderate late preterm. There is very little research done regarding voice quality in preterm infants, despite the apparent prevalence of dysphonia in preterm infants due to many reasons, but mainly intubation. As far as statistics, preterm infancy is the second leading cause of death in children under 5 years, and in 2015, roughly 1 in 10 children in the U.S. was born prematurely. As far as health complications, preterm infants experience a higher risk for long-term complications, including neurodevelopmental disabilities and recurrent health problems into childhood. Premature birth is associated with prolonged respiratory support, mechanical ventilation, and patent ductus arteriosus ligation. So PDA is a congenital heart condition, which is highly common in premature infants, and it can lead to severe health complications such as pulmonary disease and heart failure if it's left untreated. The ligation is basically just the surgical intervention that closes off the vein, which would lead blood into the lungs, and so the ligation is the surgery that prevents it. And the available evidence shows that 58% of preterm school-age children will develop voice abnormalities. So the aim of this research study was to characterize and clinically describe the voice abnormalities of former preterm infants with dysphonia. And their hypothesis is that the voice outcomes will increase in severity or be worse for children who were intubated over longer periods of time and or have had extended stays in the neonatal intensive care unit. So the participants in this study, there were 57 total participants, 26 female, 31 male. The mean age at the time of the study was 5 years old. The mean gestational age of the participants, 27.8 weeks. The length of intubation, 58 days. The time spent in NICU was 17 weeks overall. And 34 patients had cardiac comorbidities, 32 out of the 34 of which had the PDA surgery done. And 33 out of 57 patients were diagnosed with vocal fold hypofunction or immobility, and this was diagnosed using prior laryngoscopy or video stroboscopy assessments in an office that was completely separate from any assessment done in this study. So this information was gathered from their birth and medical histories. And the inclusion criteria are that they only included patients aged between 1 and 18 years whose gestational age at birth was less than 37 weeks. So in other words, they were considered preterm, obviously. And the researchers excluded all patients who were nonverbal, patients who had insufficient birth histories, or patients who have had tracheostomies. So the materials and procedures. The researchers collected data for demographics of each patient, their comorbidities, presenting symptoms, diagnoses, the office laryngoscopies or stroboscopies, like I said before, and their follow-ups. And they also obtained data regarding the NICU stay and the number of intubations per patient. So how many times they were intubated over their NICU stay. And a prolonged intubation was considered greater than 28 days. The researchers also compared characteristics of patients with vocal fold immobility versus patients who did not have vocal fold immobility. And the instrument that was used was the CAPE-V instrument, the Consensus Auditory Perceptual Evaluation of Voice, which is a highly regarded, the gold standard of auditory perceptual voice assessment. with high reliability and validity, and they used it in 38 out of the 57 patients, so 67%. The other patients, the remainder of the patients, they only used the Cape V on children who were older than 2 years and 9 months, because due to patient cooperation reasons. Any of the children under 2 years, 9 months were determined to be uncooperative during this evaluation. So the researchers who did this assessment, the SLPs, they went along the regular protocol of this assessment, which is to assess, auditorily and perceptually assess the voice quality during sustained vowel production, sentence production, and spontaneous speech, according to the domains of roughness, breathiness, strain, pitch, and overall severity. So they measured each, and they measured their level of consistency, whether they were consistent or intermittent, and whether they were mildly deviant and severely deviant on a 100-point scale. As you can see on the right, I have included just a portion of the Cape V instrument, so you can clearly see the instructions and how they assess the voice, and as well as the domains of voice, so the overall severity, roughness, breathiness, strain, and pitch, and mild, moderate, severe, consistent, inconsistent, and then the score. So the overall severity is kind of an sort of an average of all of these domains. However, it is considered its own domain. And the researchers also compared the Cape V scores for each patient with the duration of intubation in the NICU using the Spearman's rank correlation coefficient. So the results. The mean Cape V overall dysphonia severity was 46.6, and majority of the patients presented with a vocal breathiness or hoarseness. There was an increased severity in overall severity of voice for patients who had prolonged intubation in the NICU, and there was an increased overall severity for children who had a longer NICU stay. As you can see in this table, this says the Cape V, the evaluation overall mean, and the intubation days and the NICU stay, and how the intubation days that were greater than 28 days the severity is much greater in these patients versus these patients who had a shorter stay in the NICU. And some more results. Another table that shows this really focuses on vocal fold immobility, and it has 3 different measures, 3 different categories, so it further divides the vocal fold immobility into unilateral and bilateral, but we'll just really focus on the domains of voice quality in patients with no vocal fold immobility versus patients with vocal fold immobility. So in general, as you can see from these numbers, which I've highlighted over here, the patients with no vocal fold immobility in the domains of roughness, breathiness, strain, pitch, and loudness are on average much, much lower in these domains, much lower in severity versus children with any vocal fold immobility. So, of course, bilateral vocal fold immobility will be more severe will have more severe scores than unilateral vocal fold immobility, but in general, children who had any vocal fold immobility have greater dysphonia, more severe dysphonia than those without. So the results show a strong correlation between intubation history, the prolonged NICU stay, and the severity of long-term voice outcomes in formerly premature children. And they determine that the pressure from the endotracheal tubes can lead to laryngeal injuries or pathologies that can manifest in children when they are older and become more verbal. And the most common laryngeal pathologies they found were vocal fold immobility, vocal fold nodules, and posterior glottic insufficiency. And the presence of voice disorders in children may have long-term consequences in social and academic function, which includes functional and emotional difficulties from the overall medical complications they go through. And research suggests that there's a link between voice quality of life and occupational choice, which is just food for thought. It's just something to think about. And the researchers also suggest that clinicians should have a lower threshold to refer premature infants for comprehensive voice evaluations, since it is so common for preterm infants to present with dysphonia and voice complications into childhood. And they suggest that clinicians especially focus on preterm patients who have cardiac comorbidities. So the limitations to the study, the self-reported limitations from the researchers of this study were that there was a small sample size of 57. There was selection bias and limited generalization due to the fact that they only included children who presented to this one specific voice clinic in Boston. So that led to limited generalization, because since the population only included children in that one area. So they're unable really to generalize the results to all preterm infants. And there also is limited research on normative CAPE-V values which would allow them to objectively measure vocal handicap. And my personal critique of the article, so I found the strengths to be that the information was presented in a clear, concise, and direct manner. The format was well organized with a clear beginning, middle, and end, and the results allow for an obvious cause-effect relationship to be drawn. So from the results and from the tables and from how the information is laid out and presented, you're clearly able to conclude that voice abnormalities and dysphonia severity the severity increases with children who have had longer stays in the NICU and who have had longer intubation periods. The weaknesses of the study I found to be that I agreed with them that there was too small of a sample size, which highly limited generalization. And despite the study's focus on characterizing the measures of voice quality in preterm infants, they didn't disclose each patient's individual scores for each auditory perceptual domain on the CAPE-V. So I found that strange that they didn't include what each patient measured on the CAPE-V for each individual domain. And I would have found that information to be very helpful. Also, the research lacked implications for voice intervention. So I would have appreciated the researchers who did the study themselves to give insight as to what they feel the results mean as far as voice intervention. I would have found that to be helpful. And also I found that the article lacked information regarding the procedures that were done for the children who were not assessed. So, as I said, only 38 out of the 57 children were assessed using the CAPE-V instrument, but the children under 2 years, 9 months of age, there was no information or very, very little information as to the procedures they did, how they perceptually assessed those children. So I found that to be strange. And here are my references. Thank you.